introducing Dr. Jake DeDecker. He is our extension director for the state of Nevada, and he flew down from Reno this morning. So you think you got up early. He knows what early is. He's probably done this a million times. So our campus is about probably an 8-hour drive. So it's about an hour and 15-minute flight. So we do this a lot, but I'm not a fan of the 8 a.m. get up at 4 o'clock. So, or maybe it was early, I don't know. But anyway, so he's going to give our welcome before we introduce our keynote speaker. So thank you.
Well, thank you so much. And welcome to Nevada. Are you guys having a good time? It's been a good first day for not being here yesterday. Can you hear okay? All right. Yesterday I needed to be in Reno. Our president of the university was giving a State of the University address, and so I needed to be there with him, but glad to be down and join you this morning, even though it's a little bit of an early flight. I think the first thing I'd just like to say is thank you. This is such an important topic that we're wrestling with, and all of you are here maybe for a little bit different reasons, different backgrounds, which makes this work, which makes this great, is because we're all different with different experiences and what we can come to the table and tackle something as big and dynamic as what we're talking about here. I can speak for the extension directors in the West as we've talked about this. This is a priority. This is a big priority. And we want to make sure that we can invest and put resources around this and put staffing here to start thinking about what could this really look like. And I say start thinking about it because it's not that we've just started thinking about it. This has been in process for a little while, but I think it's culminated to this. It's culminated to all of you in this room listening to each other's work, thinking about what are we doing in our states. And all of you know, as we look across higher ed landscapes, as we look across our universities and our states, there's more and more investment that's going into health and the intersections with health, particularly nutrition. But when we look at the public health domain, mental health domain, clinical practices, and what those schools of medicine, those research portfolios, what do those interactions look like in the public health domain? What do those interactions look like with extension? What role can extension play in this space? It almost feels like a time where we're kind of looking out and seeing multiple beginning paths laying before us. There's some underbrush that's growing, and we're not quite sure which paths are going to be pronounced and which paths may not be, but we're all starting down different ones. We're all taking those first steps and kind of learning and saying, is this going to go somewhere? Is it going to open up into something large and exciting, or is it going to be some undergrowth that's going to take it and hide it away? We're at that stage of looking at the paths before us. It's kind of exciting to see which paths are going to emerge. And you all in this group and in the months to come are going to help us all determine which paths are worth taking. Which paths does our state, our community, our people need us to start taking? And where do those investments need to be to help us get there? So I'm excited not only for y'all being here today, but I'm excited about what's coming. What is this network going to do? What's the work that you're going to do to carry forward to really make this be a difference? Completely using the extension model that so many of us know and love. And so I want to encourage you, not just today, but as you think about this and the interactions today, take those ideas, don't let them sit in your notebooks, share them, be bold, ask questions, write down numbers, because it's the contacts that you're going to make today that's going to help flourish the ideas in the weeks and months to come. And what this network is going to be able to do and the issues you're going to tackle and bring forward are going to help drive these initiatives in the West, but likely across the country in a lot of different ways. So it's a bit of pressure, but it's also a big opportunity, and it's exciting. And that's why I'm so glad you all said yes to come here, to start learning, to engage in this network, and to help us move forward in big ways. It's things like this that we do what we do, right? We want to make a difference. We want to make a positive change. This is worth it. This is worth it. And I think this is one of the times that you're going to look back in your career and say, remember when we did that? Remember when we met in Las Vegas and started these conversations and built that network and then moved forward with the plan? I think y'all are going to remember that. And that is super exciting. The only other thing that I'll say, and I've been in this role for about a year, is Las Vegas, and I know you're really focused in here, has a certain idea on what Las Vegas is. And that casino, hospitality, resort piece, while it's certainly an economic driver and one that we pay attention to, it's such a small part of this community. This is a rich, growing community that, like so many other communities out there, needs extension, needs support, needs services, and helping to grow. And it's been a blessing getting to know what Las Vegas really is beyond the cover, beyond the shine and the glimmer of what typically it's portrayed to be. So I hope while you're here, maybe you get to experience some of that part, some of that fun part, but you also get to see the rich community that's underneath. And that's why we're here doing what we do. Do y'all have any questions for me that I can try and answer? I'm going to try and be brief. All right. Thank you, and I'm excited to see what's to come. Have a great day.
All right, so now we have our keynote speaker. She has traveled all the way from Boston and is here with us today. Dr. Cindy Leung is an assistant professor in the Chan School of Medicine. Yes, I just read all of this and I'm like, how good is my short-term memory? We're gonna see. But Dr. Leung's work is at the intersection of mental health and nutrition. She currently has a K99 R000 looking at the effect of stress interacting with obesity in children. And I'm excited to welcome her to the podium and hear more about her work. Thank you.
Good morning, everyone. Can you hear me okay? It's so nice to be here with you today. I want to thank Dr. Lindsay and Dr. Shearer for inviting me to speak. And I'm really actually just thrilled to be in a room of people who share my determination and my passion for wanting to promote good nutrition and health equity in the communities that we work in. And so most of my work centers around food insecurity. And I'm going to talk to you today about food insecurity and its impacts on health and how those work through stress and nutritional pathways, and particularly those two at the same time. But I wanted to first just start off by saying that I got started in this work right here in the Western region. So I'm from California, and I started working on food insecurity issues in 2007 at the Alameda County Community Food Bank. I feel a great affinity for this wonderful organization and food banks across the country because of the important work that they do. I was the Agency and Nutrition Services Coordinator at the ACCFB, and in that role, I coordinate our vast network of member agencies, those who receive food from our food bank and then distributed it to their clients. I led nutrition education workshops. I interacted with anti-hunger advocates across the state and across the country, and really saw firsthand the role of charitable food providers in addressing food insecurity and nutrition. This experience inspired me to go back and pursue my doctorate, and in my department, in my school, I was really immersed in all of these studies around how nutrition improves health. So how all the aspects of nutrition, from overall diet quality to macronutrients, micronutrients, and all of the compounds that are in specific foods, if we eat them in the right quantities, it can actually lead to lower risk of chronic disease and longer lifespans. And I kept thinking back to my time at the food bank and how our communities at the time and the barriers that they faced to accessing affordable, healthy food. How are we supposed to help everyone reach these nutritional goals that we have in the dietary guidelines that we know from our research is what we need to make sure that everyone stays healthy? And so just to start off, I thought we would define food security and food insecurity. The definition for food security comes from the 1996 World Food Summit. Food security exists when all people at all times have physical and economic access to safe and nutritious food that meets their dietary needs and food preferences for an active and healthy life. So lots of different components in this definition. If any one of those is missing, that could be considered food insecurity. The USDA says food insecurity is limited or uncertain availability of nutritionally adequate and safe foods, or the limited or uncertain ability to acquire acceptable foods in socially acceptable ways. Again, a lot to unpack in this definition, but food insecurity exists if our environments don't have the foods that we need to sustain health, or if they're out of reach because they're too high priced, or if our foods are not nutritious in our environment, not full of the nutrients that we need to promote health across the life course, or if we resort to having people acquire foods in socially unacceptable ways. And some would even say that standing in line at a food pantry would be socially unacceptable. So the national prevalence of food insecurity is 10%. 1 in 10 households in the US experience food insecurity at any point during the past year. But I like to show this map from Feeding America, from their Map the Meal Gap, which is a really cool tool that you can use to look at the prevalence of food insecurity in your state or in your county. And this map essentially shows that there's nowhere in the US that has a food insecurity prevalence of 0. So food insecurity exists everywhere. Some parts of the US are more concentrated than others, but otherwise, every policymaker should be concerned that there are residents in their geographic area that experience food insecurity. Now, who experiences food insecurity? The USDA publishes a report every year, kind of around this time, that reports on food insecurity over the past year. So the most recent reports from 2021, those reports always list the same characteristics of who has higher levels of food insecurity than the national average. So I told you the national average is 10%. We know these groups are at higher risk of food insecurity. Households with children, and particularly young children under age 6. Single parent headed households. Black and Hispanic headed households. Households who are close to the income or poverty ratio. And what I didn't list here, households who have a person with a disability. Every year, these are the same characteristics. They do not change. We know that these are the groups that experience food insecurity at higher levels, and these are also groups that are already structurally marginalized in different ways. So food insecurity could be exacerbating some of those disparities that we see in health. So here are the national trends in food insecurity. Since we started monitoring food insecurity in the late 1990s, we've seen food insecurity hover around 10%. In 2009, does this work? In 2009 or 2008, during the Great Recession, food insecurity peaked around 14-15%. It hovered there for several years while the economy improved. Economic improvement always reaches the lower SES communities last. So we actually didn't see a getting back to pre-recession levels of food insecurity until 2019. And we all know what happened in 2020. So I'll leave those numbers for later in the talk. But this is a conceptual model to think about how food insecurity impacts health. And I'm gonna go through some of these arrows with you in a little bit more detail. So first we can talk about this main arrow. Food insecurity, how is it a risk factor for poor health? Food insecurity affects outcomes throughout the life course. There has been a vast epidemiological literature that has shown that food insecurity is associated with negative health outcomes. Even in infancy, we see that food insecurity is associated with higher gestational weight gain, low birth weight, and sometimes birth defects. In toddlerhood, food insecurity has been associated with iron deficiency anemia, asthma, behavior problems, lower psychosocial development, and poor physical function in young children. In older children, food insecurity has been associated with poor academic performance, low diet quality, physical inactivity, poor mental health. In adolescents, also anemia and other nutrient or micronutrient deficiencies, poor mental health, and even suicide and depression. In adults, food insecurity has been associated with also micronutrient deficiencies, poor physical health, poor disease management for people who have a diagnosis with a chronic illness, poor mental health, and for older adults, we're starting to see lower cognitive performance and potentially higher risk of dementia. Focusing on the nutritional pathways, food insecurity has also been associated with cardiometabolic disease. And so many of these studies are using national representative data sets, and we see that food insecure populations have a higher prevalence of diabetes, metabolic syndrome, systemic inflammation measured through C-reactive protein, hypertension, and even non-alcoholic fatty liver disease. We also looked at this in a recent paper. We used the American Heart Association's new Life's Essential 8. So this is a composite score of 8 modifiable behaviors and risk factors that are supposed to predict long-term cardiovascular health. And so there's things like tobacco use, sleep, physical activity, diet, and there's 4 more. Each of these are scored from 0 to 100. So if you get a score of 100, that means that you are perfect with that behavior. So for example, if you've never smoked in your whole life, you would get a tobacco use score of 100. If you had a very high diet quality as measured through the healthy eating index or the DASH diet, you could get a score of 100 and so forth. And what we see is that, at least for these modifiable behaviors, there were these inverse associations with food insecurity. So the more severe someone was with their household food insecurity, the lower the mean levels were for these scores. And so you can see there's this kind of trend across each of these. As food insecurity worsens, the ability for someone to adhere to this cardioprotective behavior is lower. And these are the other components of Life's Essential 8. And again, we see some significant associations. There was a significant difference with some of these groups, particularly the low food secure group and the high food secure group for BMI, for serum glucose. And then the ideal score, which is an average across all of these, show that this very clear dose response kind of gradient, where that the more severe someone's food insecurity, the lower their ability to achieve ideal cardiovascular health. And this was noteworthy to me because on the previous slide, things like tobacco use and sleep, these are not things that we associate often with food insecurity. We think about food insecurity as impacting diet and glucose and things that are measured in the blood as a response to diet, but food insecurity is impacting other health behaviors too. So we can talk a little bit more about the nutrition pathway. I'm trained as a nutrition epidemiologist, and so this is an area that I really started to, I was really interested in because I wanted to know what aspects of diet were being impacted by people who were food insecure. We've done this in a number of different studies. We've used different measures of diet quality. So this one is the Healthy Eating Index, 2005, and this is the Alternate Healthy Eating Index, which is modified version of this one, but with a little bit stricter criteria for what counts as certain foods or food groups. So for example, fruit juice counts as a fruit component for the HEI, but it does not count as a fruit component or a serving of fruit for the AHEI, and so forth. So there's slight differences. But for both of these indices, which are measures of overall diet quality, meaning a higher score means more healthy, more healthful diet, we see, again, a similar dose response where the higher your food security, the higher your diet quality. And the more severe your food insecurity, the lower your diet quality. We did a similar study during COVID, and we saw, again, a similar stepwise pattern. This is another measure of diet quality. This is a very simple tool. You don't need to do a 24-hour diet recall or administer a lengthy food frequency questionnaire. It's a short 22-item screener called the Prime Diet Quality Score. That's what this is. And a higher score, again, means higher diet quality. The nice thing about this was because there were so few questions, 22 compared to like 120 in a food frequency questionnaire, we can actually look at which components of diet were significantly different across levels of food insecurity. And we were struck that it wasn't just that people who were food insecure had a harder time eating fruits and vegetables, it was every aspect of diet quality was being impacted. So things like fewer cruciferous vegetables, fewer dark green vegetables, fewer nuts and seeds, less fish, which we know is good for cardiovascular health, more processed meats, more refined grains, fewer whole grains. Almost every item that we asked about was significantly different by food insecurity. So When we're talking about interventions, a lot of times we focus on fruits and vegetables. And fruits and vegetables is important for moving the needle, but we also have to think about everything else that's part of that diet. Now, ultra-processed foods is getting a lot of attention right now, and we've also done a study looking at food insecurity in ultra-processed foods. Similar stepwise pattern where the more severe someone's food insecurity, the higher their average intake is from foods that are ultra-processed. And so the mean for someone from for the very low food secure adults was around 56%. 56% of the total energy was coming from ultra-processed foods. So why do these associations exist? Well, I've done some qualitative work in this area, which I'm going to show you. And one of these was it was a community-based participatory research project that I led in San Francisco, or in the San Francisco Bay Area. We interviewed parents or caregivers of children ages 7 to 14 who had endorsed at least one item of food insecurity on the USDA measure. And then of those parents, we also asked them to complete a sub-study where they could use the photo voice method. So this is where people can use their cameras, their smartphones, and take pictures around a certain theme. The pictures that they sent back led us to conclude some of these challenges around food insecurity. So why do these associations exist? Well, one of the major themes was that the environment nudges us towards the foods that do not support health. So I have their exact quotes because I don't want to misrepresent. This was a photo taken by a mother, also a teacher, so she really liked this project. But she said, she took this picture from this angle to say there's very little fruit because it's so expensive. I'm caged in my purchase of fruits and vegetables by the prices. This is another photo. Another mother took this. You can see it's orange juice, $6.99 each. She said, I think people in poverty are being punished because they can't afford orange juice. They can't afford healthy food for their kids. They have to give them Kool-Aid and Sunny D. That's sad. Here's another photo. This was taken in San Francisco. This was a local grocery store that catered to a lower income population. And so you can see that this was like a little outlet from the grocery store next to the checkout. And at the very bottom, it says, you buy, we fry. There's a picture of SNAP and EBT. And basically, it's the loophole for not being able to get prepared food with your EBT benefits. If you buy a pack of raw chicken with your EBT benefits, you can take it here and you can pay, I don't actually know how much, but you can pay them and they will fry it up for you so you can bring home fried chicken for dinner. The participant who took this, and she described it to us, she was very angry. She said, when you go into Super Save, coincidentally, everything that you can buy for your home to make a home-cooked meal is very, very expensive. But soda and fried food, they're cheap. When you go into Super Save, it smells like grease from the fried chicken hut. If you buy chicken from the meat area, they will fry it for you. It's like, come in and get fat, you know? Buy this cheap soda. Don't buy all this other high-quality stuff because we don't want you to make a decent quality meal. We want you to eat fried chicken and drink cheap dollar-gallon soda. So the environment nudges us towards making unhealthy food choices, which is magnified if you have fewer resources. So now let's talk about the stress and mental health piece. We know that there is a strong psychological component to food insecurity. It was part of the core dimensions of food security very early on when Kathy Radimer developed the food security scale that we now use for the USDA measure. In fact, the first question is, how often did you worry your food would run out before you had money to buy more? And 90 to 95% of food insecure households endorse this question. We know that this is one of the earliest indicators of food insecurity, is anxiety about your food supply. Just not even having to change your behaviors, but just thinking that maybe your food's not going to run out. So this is a pretty universal phenomenon for people who experience food insecurity. We've looked at food insecurity and global measures of mental health. This is the Kessler Psychological Distress Scale. And we see that if you have low or very low food security, you have much higher odds of reporting serious psychological distress compared to the food secure group. And some of these associations are particularly strong if you're male, or if you're a caregiver of children, or if you're a SNAP recipient. We have looked at food insecurity in relation to other measures of mental health. This is the Cohen's Perceived Stress Scale. This is the PHQ-2 for anxiety and the PHQ-2 for depression. So these are all screeners that we can put in a larger health survey. And these are pretty robust findings. No matter which measure we use, what we adjust for in the model, we still see that the more food insecure someone is, the more likely they are to report poor mental health. The question that has come back to me is whether there's other things going on that are contributing to poor mental health. So is it food insecurity, or is it all the other stuff that people go through? Things like poverty or discrimination or living in a stressful neighborhood where they can't get good sleep. So this was part of the qualitative study that I showed you previously. We talked with 48 parent-child dyads. I'm only going to show you the results of the parents here. The children's results are a different talk. But basically, we conducted semi-structured interviews with the parents or the caregivers around their experience with food insecurity, and we specifically probed to understand the stressful aspect of food insecurity, or was there other stressors that they were dealing with. And then we did all of the things for qualitative data analysis, and I'll show you some of the themes. Some characteristics of the family. Mostly mothers in this study. These were the mothers were more likely to respond to our study ad. They were also the ones who tended to manage the household food budget, were the primary food shopper, but we also had a few fathers in the study as well. It was a very low food secure sample. So the first thing that we asked them to talk to us about was the stress of food insecurity. And I can tell you, every parent, when we asked them this initial question, it was like opening up the floodgates. Everyone had a story to tell. No one said that this was not stressful. One of the mothers said it was like juggling 10 plates and you can't drop one. This other mother, she said, if I ever got hit by a bus, everybody would be SOL. I feel like I am the spoke that holds everything together in terms of working and doing all the food shopping and doing all the budgeting. It's really stressful because nobody can share the burden. But on top of the stress, we actually heard a lot of other dimensions of psychological distress when people talked about their experience of food insecurity. So we heard people feel like they were powerless. They didn't have a choice about the foods that they were buying to feed their family. They were constrained by the prices and the places that they could shop at. One person said, we get tired of being the same thing over and over, but what can I do? Canned chili and rice, sort of healthy, but it's something we eat all the time. Hot dogs, again, all this processed food. We don't have a choice. I have to buy what we can make the most out of, what we can make last. Always the unhealthy stuff that we are stuck buying. This mother was particularly angry. She was sharing how she would go try to buy cereal for her 3 children, and she would go to, I think she said it was the drugstore because they would have sales, and she could buy $1 a box of sugary cereal or pay $5 for the whole grain cereal. And she bought 5 boxes of the unhealthy cereal because she needed to feed her children. And she was so angry paying for this at the drugstore because she had no choice but to buy that in order to stretch out her food budget. On top of that, we heard themes like feeling alienated or isolated from their social groups, feeling shame or stigma, feeling sadness and depression, and feeling guilt, which was very salient coming from the perspective of a parent. So I have some other quotes I'll let you read to yourself. So coming back to the question of, is food insecurity stressful? I would say yes. And it's not just stress or anxiety or worrying your food is gonna run out. It's all of this. And one parent even said that food was different than all of her other bills because the rent, the car payments, those are once a month. She pays it, she doesn't think about it till next month. But food is the thing that she thinks about multiple times a day. In the morning, what am I gonna pack for my kids for their lunch? At night, what am I gonna feed them for breakfast? So it is this, I mean, if we think about all the food choices that we make every day, that would be amplified if you have multiple mouths to take care of and you have a very limited food budget. So we also talked about how do they manage with their stress. And we heard a lot of elements of positive coping, which is very reaffirming. People talked about relying on their friends and family for support. I think one person talked about seeking mental health counseling, spending time with their children because that made them happy, praying, and then just trying to stay optimistic. Also heard a couple themes of negative coping. One person said they just avoided interaction with others. That also meant their children. So sometimes they would just go in the room and close the door and go to sleep. Sleeping was a big one. So just trying to sleep away the worry and the hunger. And then one person talked about drinking to try to cope with the stress. And they said, it's not a good solution. I'm not proud of it, but I have to stop thinking so much. So drinking and thinking don't go together, right? So why do these associations exist? Well, the environment's nudging us towards the wrong foods, but also for those who go through food insecurity, it's a source of toxic stress. It's not just stress, it's toxic stress. And I'm borrowing this term from the children's literature. I know normally we talk about toxic stress in the form of children's development, but food insecurity meets all the criteria of a toxic stressor. And why shouldn't those same criteria be applied for adults as well in order for them to maintain good health for the rest as they age? So food insecurity is a source of toxic stress. This was another photo that one of our participants shared. It's a beautiful plate of food. She said, eating healthy is really good, but it's hard to deal with meal planning and budgeting. I feel like a failure most times because I can never get it right. We got a lot of pictures of food that people cooked, and so this was another one. Right next to this was a pot of white rice, so that was their dinner. And the mother said, it's the middle of the month and the food is low. You run out of hope. That's how it feels right now, hope. The end of the month is like a week and a half away. My son comes home every day and says there's nothing to eat. And then finally, this was one of the photos I had on my title slide. But this mother said, every once in a while, we get the rare opportunity to eat out, and my son always picks a burger and fries. Doesn't happen much, but when it does, I feel a sense of normalcy. Like maybe I'm not that much different from other families. Okay, so now let's talk about this middle arrow. We know food insecurity relates to nutrition. We know it relates to stress and mental health. So what about the intersection of these two things? Well, there's a lot of pathways by which stress and mental health and also nutrition can be connected. So one of these is cognition. Cognition is important for things like self-regulation. We need to have good self-regulation to eat a healthy diet, to make sure that we're buying all the foods at the grocery store, staying within our budget. And when we're stressed, that impacts our ability to have self-regulation. So it leads to things like more impulsive behaviors. Do you guys remember the marshmallow experiment? Classic Stanford experiment. The videos are adorable with the children with the marshmallows in front of them. My 3-year-old would definitely not be able to pass that up. But it's a measure of delayed gratification. Well, the opposite of that is impulsivity. And there have been modifications to the marshmallow experiment now, so that if you randomize a child to an unreliable environment before you give them the marshmallow or the Oreo or whatever treat, if they're randomized to the unreliable environment, they're not going to wait to eat the marshmallow. We've seen that. If you give the marshmallow experiment and you look at a children's history of cumulative stressors, which include things like poverty, but I don't think that study looked at food insecurity. But if you account for a child's stressors, those who experience more cumulative stressors, even during childhood, are not going to wait for the marshmallow. So they're being conditioned to be more impulsive because they don't know what their environment is going to be like. And that's going to impact executive functioning. So for older adults now, we have seen that food insecurity is associated with with lower performance on executive functioning tasks, including things like memory and working memory and processing speed, inhibition. And so all of these things are related to the stress response and can impact nutritional choices. Another aspect is physiology. So we know stress activates the HPA axis, or the hypothalamic pituitary adrenal axis. That leads to a cascade of activities that increases the release of cortisol. Cortisol works throughout our whole body. Cortisol drives people to eat, especially the highly palatable foods. Cortisol leads to greater fat accumulation. And cortisol also stimulates reward centers in the brain. So when we're stressed, we release cortisol and we release dopamine. And that means that it makes us crave things that are more highly palatable, high fat, high sugar, high salt foods. And those can actually help to blunt the stress response. I know when I'm stressed and I reach for the brownie, sometimes it makes me feel better. This is a normal phenomenon. And we're seeing that if you're chronically stressed, doesn't matter if it's food insecurity or caregiving burden or some other form of chronic stressor, you're more likely to engage in reward-driven eating. And then biology. So I talked about cortisol, but then there's also stress impacts on our appetite regulating hormones like leptin and ghrelin, as well as peptides like neuropeptide Y. I would say that the evidence on stress impacting these hormones and other biological factors is much stronger, but the link to how these then impact appetite and nutrition and how these are different in food insecure populations is still very early. So I don't have a lot of research for you to share in that realm, but just want to show that all of these are interconnected. And so when we think about food insecurity as a nutritional issue, as a psychological issue, we are activating all of these systems at the same time. And so all of these are then contributing to the poor physical and mental health outcomes I showed you at the beginning of the talk. And that's also why we're seeing things like populations of food insecurity are reporting higher levels of dietary restraint, higher levels of disordered eating behaviors. I had a wonderful doctoral student, Michaela Berry, who worked on this topic and found that it doesn't matter which measure of disordered eating, that there was a higher level observed in a food insecure population. And her 2022 paper was in children. She found that if a child reported food insecurity, they're more likely to also exhibit disordered eating behaviors, much less so than if the household reported food insecurity. Food addiction. So this is another amazing doctoral student, Lindsay Parnaruskis. She published the only paper so far that I know of on food insecurity and food addiction in 2 different samples of women in California and Michigan. Food addiction is a paradigm developed by Ashley Gearhart at Michigan that basically uses the DSM-5 criteria for substance use disorder addiction and modifies those for foods, and specifically for ultra-processed foods. So there's a prompt at the beginning of the questionnaire that says, when you think about foods that you have a problem controlling, and she gives a list of things like cookies and potato chips and hamburgers and chocolate. And to answer those questions in response to those foods or any other foods that someone might have a problem with. And they're the classic symptoms of things like withdrawal, tolerance, unsuccessful attempts to quit, and so forth. So food insecurity is linked to food addiction. And then Vivian Hazard has been publishing a lot of different studies showing that food insecurity is associated with clinical eating disorders. And so bulimia spectrum eating disorders and binge eating disorders have been the 2 that she's found in studies of younger adults. So where do we go from here? Now that we know that these pathways are acting simultaneously, how do we solve this very intricate puzzle? And I don't have any answers for you, but I'm thrilled to be with a team of leaders like you that have the ability to brainstorm what would be the best for your communities. And I wanted to show a couple things around COVID, because I think even though the pandemic was devastating, we can learn a lot of lessons about food assistance that we should be carrying forward to this next post-pandemic era. So even though we saw those lines at the pantries, we saw the news reports about food insecurity go up, the empty shelves at the beginning of the pandemic, many of us who study this were shocked when we saw that the national prevalence of food insecurity in 2020 and 2021 were the same. 10%, 10.5 in 2020, 10.2 in 2021. No significant difference from 2019. How can that be? When we all saw what was happening on the ground. Part of what I think was happening, if we trust the data, which USDA does, is that, well, we really mobilize our food assistance programs. And the one example I'll give you is SNAP, but SNAP obviously was not the only thing to happen. So very early in the pandemic, Families First Coronavirus Response Act of March 2020, we raised SNAP benefit allotments to the maximum. We relaxed the 3-month limit for able-bodied adults without dependents to receive benefits, so they didn't have to continue working or recertify. We provide states greater flexibility to recertify, so that means states could have longer recertification periods. They could allow people to verify their signature over the phone rather than going to an office in person. And then we increased SNAP benefits again. In 2021, we allowed states greater support to make sure people could get on SNAP as quickly as possible. We greatly expanded the online purchasing pilot so people on SNAP could use their benefits to buy food online for delivery. And then through a White House executive order, but was actually part of the 2018 Farm Bill, we finally modernized the Thrifty Food Plan from 2006. So this led to a permanent increase in SNAP benefits that wasn't tied to the pandemic. And this has been sustained and then is reevaluated, so it's adjusted for cost of living every October. But all of these other things have gone away now that the public health emergency declaration is over. We know also that when you give households money, it doesn't have to be in the form of an EBT card. When you give a household money, a stimulus check payment, or a child tax credit, that leads to an immediate reduction in food insufficiency. So this was all happening in real time during the pandemic. We don't think about child tax credits as being a food insecurity solution. We don't think about stimulus payments or other economic policies as being a solution to food insecurity, but maybe we should. So where do we go from here? Well, this is a Farm Bill year. There's a lot of stuff happening in the House and the Senate around what the next Farm Bill is going to look like. And I think whatever lessons we've learned around COVID, which could be national, could be state, it could be county specific, what worked for that agency, can we try to carry it forward into and make it permanent? So maybe that's extending recertification periods. Maybe that's giving more support to SNAP workers in the offices. Maybe that's increasing benefits, relaxing work requirements. All of these things, if you can reduce administrative burden for SNAP and other federal food programs, or at least streamline eligibility so people can get on as many programs as they are eligible for with one application, that will improve food insecurity. And then focus on nutrition and food access. Income assistance is what I was just talking about with the figure. Temporary assistance for needy families. It's an income program. We don't think about it as a solution to food insecurity, but it absolutely should be. Stimulus payments, cash transfer programs. We had that in a neighboring county in Boston. In Chelsea, we had an unconditional cash transfer program for our predominantly Hispanic community. And we're evaluating that now to see if that improved diet and food insecurity for the residents. Supporting working class families with children. So when we expanded the child tax credit during the pandemic so that lower income families could receive the benefit, more Black and Hispanic and other families of color could receive the benefit, we actually saw an improvement in family mental health. So we know that these are working to improve mental health and improve food insecurity. Subsidized childcare, universal pre-K programs, all of these are important. And then comprehensive food assistance, health promotion, and social support programs. So the main takeaways that I want to share with you today are just food insecurity is a really critical social determinant of physical and mental health. It has excessive healthcare expenditures. So whatever actions that we can take to make sure we eliminate food insecurity, the better off our economy will be, as well as the health of our citizens. Food insecurity definitely has both a nutritional and a psychological concern. We focus a lot on the nutritional piece, but I think the psychological piece should get equal weight, and how those two intersect. And then finally, more work is needed to identify the best practices on how we can simultaneously alleviate food insecurity and improve population nutrition and mental health, so we can really promote health equity for all the people that we serve. So thank you very much.
All right, so now we have about 15 minutes for questions. So anyone have any questions for Dr. Leung? I'll run this mic back to you. It's my physical activity.
Where's the question? Where's it? Oh. Okay.
Thank you for that awesome presentation full of information that was just so relevant to today's topic. Can you tell us, could you go through all 8 of the cardioprotective categories?
Oh, sure. Let me pull up that slide again so it's easier. That is an updated definition from the previous one, which had 7. Now we have 8 criteria from the American Heart Association. So it's tobacco use, sleep, getting adequate sleep, I think between 7 to 8 hours would give you a perfect score, but too much or too little sleep, and there's different scoring criteria for each of those. Physical activity and diet. The original paper by, I believe, Dr. Donald Lloyd Jones has the scoring criteria for each one of these metrics for both children and adults. And then the other 4 are BMI, serum lipids, which I believe is cholesterol and triglycerides, serum glucose, and then blood pressure, systolic and diastolic. So those 8 together comprise what they call ideal cardiovascular health. Sleep was the new one that was added before. Before it was the same 7, and then just last year they added sleep because they realized sleep is a very important health behavior.
Other questions? Oh, here we go.
Thank you very, very much for your presentation. I'm curious, since you laid it out so clearly, are you aware of other places where this conversation is happening, whether it's in divisions of government, departments of government, or professional associations where people are really coming together like we're trying to do an extension around this intersection?
That's a tough question. I think what drew me here today was because of the strong focus on mental health. I'm in a department of nutrition, and we are very hyper-focused on nutrition. And I know in this kind of surrounding schools and where spaces where my colleagues are working, nutrition security, food as medicine initiatives, all of which focus on nutritional support, is really like the new shiny thing that everyone in this field is going to. So I try to make my case as best as I can that mental health, the psychological component, is equally as strong in driving these health outcomes that we see. But I don't know of any other network or group of people that is placing equal weight on nutrition and mental health when it's addressing food insecurity or talking about food access or food systems, which is why when I read the description of this network, I thought it was amazing that that is both of those things are in the name, and both of those are part of the conversation together. And the only reason that I know about that I work in this area was because I did my doctorate in nutrition, where I didn't learn a single thing about stress and how stress relates to eating. And I did a postdoc in a field in health psychology. And so I really tried to marry those two disciplines, bring my work forward. And I would love to have more conversations with you all here about the work that you're doing that's addressing those two issues.
I just want to say that's incredible. I mean, I think it's what we've been talking about. It just reminds us that you can be in one area and say, this is my scope of the work. I don't do that. But if we don't enter that space, nothing's going to happen. So thank you for boldly going into a space that's not, because it really, really made impact. I think I saw a question up here. Yeah. Make sure you state your name and where you're from too.
Hello,
Hi.
I'm Claire. I'm an RD student at Berkeley.
Hi.
Really appreciate your talk today. I was wondering if you could expand a little more on your current research project.
Great questions. I have a project right now that's looking at food insecurity among older adults. And so we are focused on the outcomes of cognitive impairment and dementia risk. Thinking about food insecurity as a really important component of socioeconomic disadvantage. There's a lot more research on education leading to dementia risk or socioeconomic status, but food insecurity isn't really part of that. And we know that people who can attain a high diet quality, like Mediterranean diet, is supposed to be for dementia prevention, but how does that actually relate to food insecurity? So we're doing some work in that area. I also just think older adults are a population that oftentimes get ignored when we're talking about food insecurity, because everyone wants to focus on children and their families for very good reason. And older adults, because they on average have higher diet quality, a lot of times they just get overlooked when we're talking about nutrition and food insecurity. But there are such unique struggles and barriers to food access for our aging populations, especially if they have access issues or mobility issues, or they're isolated. And so trying to untangle and better understand the experience of food insecurity for older adults is something that I'm working on. And then a new project that I'm now starting is to understand some of those pandemic era changes to SNAP and how that varied across states over the course of the pandemic, and how the de-implementation of those policies is impacting SNAP participants' diet, mental health, and food insecurity. I am hiring for that project, so if anyone has a project coordinator, a research assistant, an analyst who would love to work in Boston, I would love to chat.
Hi, Sri Vitarana, Nutrition Policy Institute, UC Aga Natural Resources. Thank you for the really interesting, fantastic presentation. I was curious, I know that to get sort of measures of mental health and stress behaviors, qualitative research is really powerful, but I was wondering if you had sort of recommendations for questions, or if there are already created scores that we can include in quantitative surveys that are particularly useful when looking at nutrition and food insecurity in relation to mental health and stress?
Yeah, that's a good question. And it's one that we struggle with too in our work. Most of the scales that are developed to assess mental health are global. So they're not, the only one that I've seen that's specific to a certain condition is there are stress around diabetes, distress. But otherwise, there are no food insecurity specific stress scales. I actually ventured down that road and tried to develop my own using some of the quotes that we had heard from our study participants. And what I eventually concluded was the more severe a family's food insecurity was, the more of those items that I developed around psychological distress specific to food, they were going to endorse. And so it didn't seem to me that there was anything extra that scale was capturing. So I did not decide to go through all the steps of validation to make sure that this was necessary. Time and time again, I go back to the traditional USDA 18-item measure, even though it was developed among women with children in upstate New York in the early 1990s, that scale, those items have been tested and validated time and time again. And they're so widely used that I would hate to diverge and use another measure of food insecurity, because then we can't compare our assessments. And so I still think that scale, if you analyze it either continuously or using all the different categories of food security to really get to understand the severity, and not just people say food secure or food insecure as a dichotomous outcome, but to like look at the different levels of food security specifically. That stress, I think, is embedded within those categories.
Hi, I'm Dusty with Oregon State University Extension Service. I'm a person that works in communities, in rural communities across Oregon, at the intersection of food insecurity and mental health. I'm wondering your thoughts about interventions to help us prevent that stress and depression and all those other outcomes you talked about that are caused by food insecurity and other related factors. I know you said that you look to the communities to implement those kinds of interventions, and that's us in this room. So I'd appreciate your thoughts on where can we have the most bang for our buck in helping communities and individuals with the food insecurity related stress.
I think the approach that I've heard the most from people with food insecurity or people using SNAP has been to just either provide more benefits so that people have more EBT dollars to spend at the grocery store, or to provide them with more money. That seems to be what people always come back to. I think in the health psych realm, where I did my postdoctoral training and I worked a lot alongside health psychologists, the response was like, well, you know, there's counseling, but you can't counsel someone outside of food insecurity, right? It's not like nutrition education is wonderful, but you can't educate someone out of food insecurity. And so realizing that there's structural drivers of food insecurity, how do we figure out the economic solutions to that? So a lot of my work focuses on these national policies and evaluating them. But at Drexel, they have an incredible, I think it's called Health is Wealth, or maybe I'm mixing it up. Maybe it's Wealth is Health. It's led by Mariana Chilton, and she basically taught women with low incomes who might also have had children, financial literacy, and whatever money they put into a savings account, they matched. And they did not talk about food at all in that intervention. And they were able to show that food insecurity dropped among the people in that intervention. So maybe part of that is the financial literacy piece, but just giving people more money, we know, is a tried and true solution. But of course, there's a lot of that's not politically easy to do. So I think talking with the people that we serve and trying to figure out what their struggles are, that seems to be like, I can't imagine there's a one-size-fits-all solution, but from my conversations, it always tends to come back to give us more money.
Hello, Melana Charles with Oregon State University Extension. I work with family community health and SNAP-Ed, specifically African immigrants and refugees and African Americans. I have two questions. My first one is, can you define ultra-processed foods and give an example as opposed to just processed foods?
Yeah, sure. Ultra-processed foods is a term that's been coined. Recently, there's a classification system called the NOVA classification, N-O-V-A. And they basically categorize any food or food product into minimally or unprocessed. That's level 1. Level 2, I think, is a processed culinary ingredient, so something like olive oil. And then number 3 is a processed food. And number 4 is an ultra-processed food. So ultra-processed foods are the foods with the highest degrees of processing. They usually contain ingredients that are only found in the food industry, so not something that people would keep in their home, in their kitchens at home. So there's things that are ultra processed, containing industrial additives to be very shelf stable. So examples would be like ready to eat or frozen meals, sugary cereals, sugar sweetened beverages, things that really have like a high level of salt and sugar and or fat, more than what we would add ourselves if we were preparing it at home.
Thank you. My second question is from the slide, consequences across the life cycle. I know it started off with the youth all the way up to seniors, but I'm wondering what has been found as relates to when that baby is in utero, and how does food insecurity of a pregnant mom impact the child moving forward throughout the life course?
That would be an amazing grant to write together if you wanted to work with me. The challenge with that is you need to have a birth cohort. So that means a study where you follow pregnant women early in their pregnancy and then follow them until their child is grown. And so a lot of the birth cohorts that we have in the United States and around the world, I have not seen, this just me, I haven't seen studies that have been able to assess food insecurity during pregnancy and then can look later on to see offspring development and health. But I think that is an incredibly valuable question that goes back to our developmental origins of health and disease. Because we know that there are exposures in utero and even the first year of life that set a child up for certain metabolic conditions later on. So where does food insecurity play into that? Because it's not just the nutritional aspect now, we know it's the stress. We know that the stress is transmitted to the fetus. So I think that is a phenomenal research question, and I hope there's research coming out around this, or at least like the start of a new study, a new cohort that would be able to establish the grounds for that kind of question. Thank you.
Sorry. Yeah. We had one back here too. Okay.
Hi, I'm Beth. I'm from the University of Minnesota Extension, and I've worked in food access for a while. I also just did my MPH project on the impacts of food access on mental health, so it's definitely resonated with me. But one of the things that has really bothered me about food access work for a while is the lack of accurate data on food insecurity. I know that you share the Feeding America website, which collects most of the data from people who visit food pantries. And we know that there's a huge stigma for people actually going to a food pantry, even if they are food insecure. So I'm wondering if you know of any better ways to collect that data, or if you've seen any research that kind of captures that data more accurately.
Yeah, data is very important to inform our work, and it's challenging when the data that you need is not available. A lot of the data for USDA comes from the American Community Survey, the Current Population Supplement. So that's where we get our annual statistics for food insecurity, where I showed like these trends. That's all coming from the same data, same survey that's administered every year. It's national. I have never tried to access it myself, so I don't know if you can get geocoded data and actually look within your state to see. I will also caveat, and hopefully no one from USDA will be mad at me for saying this, but they only asked the Household Food Security Survey supplement to families who are, I think, below 185% or 200% of the poverty level. We know that there's people above 200% of poverty who experience food insecurity. So especially when I saw those 2020 numbers, I started to think that maybe the food insecurity estimates that we have are underestimated. Maybe actual true food insecurity is higher. And we've done statewide surveys in Massachusetts through the Greater Boston Food Bank of residents during COVID during the pandemic each year, they have been far higher than what we see from the national data sets. So sometimes the best approach is to go out and collect your own data, or if you have a very strong analyst and they can work with geocoded data. I think a lot of our large national health surveys like NHANES, NHIS, the BRFSS, they all ask variations of the food security questions, and they probably also have geocoded data that's restricted. So if you were able to access those, and you could get some more specific estimates for your region. But sometimes the best approach is to collect your own, which requires money and people.
So just a final comment, and we're going to close back to your comment about interventions. I love that you can't educate people out of it. But one of the roles of a lot of people here that when we refer to interventions is also policy and systems and efforts like that. So I think you bring up the good point that that's a big thing that we need to focus more on, and not just direct education. Direct education is good. For instance, we've been having discussions possibly with substance use when people go to outpatients, setting up food pantries there to help provide access to food when people are coming there for substance use treatment, as well as the education. And I also want to mention that there's, I believe it's University of Kentucky Extension just is unrolling a program called Profit, which is for people in recovery to help them with managing budgets and food insecurity. So anyway, let's give Dr. Cindy Leung a big hand.
So really quickly, my name's Cassandra Nguyen. I'm a member of the planning committee, and I had the pleasure yesterday of giving a very brief kind of 10, 15-minute presentation on food security and mental health. And I characterize this as an appetizer to your talk today. And I hope everybody can agree with me that we really got an intellectual kind of 5-course meal. So I want to just say thank you. We so appreciate you traveling out here from the East Coast to join us and really inspire us with your knowledge and all the work that you've done. So as a member of the planning committee, I want to give you a brief or a small gift, and as a token of thank you for being here. And I want to just invite everybody to again give you a round of applause for joining us today in your presentation.